We're still continuing to talk exercise in the EASD live studio. And with me now I have Ronnie Aronson. Ronnie is from Toronto in Canada. And Ronnie, you've got a very interesting poster on high-intensity interval training. Is it something that people might not know about? Just explain what high-intensity training is.
High-intensity training, interval training, can take many forms, but usually there are intervals of aggressive activity punctuated by rest, and the activity can take many different forms, but are commonly cycling at high rates and against high power output, or calisthenics and multiple muscle groups, multiple rotations. Viewers might know it most commonly by the brand of CrossFit. But it can take many different forms.
So basically, go at it like mad for a short while, and then it's very effective. So tell me the problems that has for type 1 diabetics, because I presume that hypoglycemia might be an issue.
And most clinicians are concerned about hypoglycemia as a result of exercise, and may not realize that after this type of exercise, which is very popular and increasing in popularity, this type of exercise can produce hyperglycemia. And it's affecting more of our patients because high-intensity interval training was just named by the American College of Sports Medicine as the #1 exercise globally in 2018.
Gosh. Yeah. So tell me what your poster is.
So clinicians at this point don't know the reliability of the effect of high-intensity interval training. Let's call it HIIT going forward. They don't know the reliability of the glucose effect, and they don't know how to treat it. They don't know whether patients should correct it at all or correct it aggressively. And you see a wide range of behavior among patients who find themselves in that situation. So we took 17 patients with type 1 diabetes and made sure they were fit. These were regular exercises. They went through exercise testing and had reached a certain threshold to qualify them. They had reasonable glycemic control. And then we put them through sequential sessions of the same exercise over and over again, 1 week apart, staying in clinic for 24 hours after each session so we could monitor them.
And so Ronnie Aronson, the torturer, forcing them to do all this exercise. But how do they fare?
I took turns in torturing with the rest of our authorship group. So and then at each session, we randomly sequenced them to receive either 0% of their correction bolus based on their own insulin sensitivity factor, or 50% of their usual, or 100%, or 150% of their usual correction factor. And what we found was that we conducted, for example, 74 sessions of exercise, 71 sessions, and 64 of them resulted in hyperglycemia. So 90% of the time, this type of exercise will produce hyperglycemia. We found that there was actually quite good correlation from session to session in the same individual. If you were likely to reach a certain level of hyperglycemia, you were likely to do that every time, which is an important finding. We found that it correlated well with catecholamine levels, but particularly well with the degree of lactate elevation, which we measured during the exercise. The most important finding was that hyperglycemia resulted so that patients moved from a mean of 8.8 before the exercise to 12 at the end of exercise, to 12.7 after our planned 15-minute rest period. So 25 minutes of exercise plus 15 minutes of rest caused a 3.9 millimolar elevation in blood glucose.
And how did they fare with these different strategies for correction?
So essentially, we found that the most effective correction was either the 100% of their usual or 150%, which lowered their from peak post-exercise hyperglycemia at the 3-hour point, which was our primary outcome. So 3 hours later, they've reduced by 5.3 millimole with the 150% correction and 4.7 millimole with the 100% correction. Those were both significantly better than 50% or no correction and not different from each other statistically. The 50% correction did improve their blood sugar by 2.7 millimolar, so accomplishing something. No correction allowed them to become persistently hyperglycemic and rise further by a further millimole, such that their mean was over 14 if they had not taken a correction at all by the 3-hour point.
So this is a really important piece of information to get out there, isn't it?
It is. This should be guideline changing, because we have several position papers and guideline comments about how to manage exercise, but it's all geared for the concern about hypoglycemia.
Yes.
And there's often reference to the fact that hyperglycemia can follow some types of exercise, but no direction as to what to do with it. We think this finding should give quite clear directions to caregivers and patients as to what they can do in that setting.
And of course, people with type 1 very often don't consider themselves patients at all, because in general they're much younger and exercise is part of their routine. So this kind of information needs to get out to the likes of YouTube and the social media channels, I suspect, as much as to doctors and diabetologists.
Yes, I imagine that will help reach more patients. Yes. Exercise is well recognized to improve patient health, people living with diabetes, their health, their fitness level, their muscle tone, their diabetes care. But many patients find they can't fit exercise into their routine because of concerns just like this. Either hypoglycemia for some types of exercise or hyperglycemia. So giving them the skill set to know what to do to treat that once it happens, I think will allow more patients to gravitate towards more exercise.
Terrific. What an interesting piece of work. So there you have it, the last in our collection of sessions on exercise, and you can find this poster and indeed the other sessions that we've been talking about on EASD.org.